All right, so Mary Free Bed is a freestanding inpatient rehab facility located in Grand Rapids, Michigan. We underwent a recent expansion in 2014 that increased our beds from 80 to 120. This is a picture of the clinicians on the stroke unit who participated in the study. We have 4.5 full-time physical therapists and a physical therapy assistant. And over the course of the study, we saw a 50% increase in our admissions and had over 500 patients admitted to the team last year. Mary Free Bed has a vision to establish itself as a learning health system. For us, that meant that we would become a data-driven healthcare system that uses patient care-related outcomes to impact quality improvement and best care practices. Over the next few slides, I'm going to tell you about the implementation of this project at Mary Free Bed, how we refer to the phases of the study as usual care and the high-intensity gait training phase, the barriers and facilitators that we encountered, and the strategies that we used to encourage the adoption of high-intensity training. Roberta will continue with the results of the high-intensity phase, and spoiler alert, we are the site that had the surprising results. So our implementation story started with administration and research staff being approached with the opportunity to participate in a multi-site research study with the goal of adopting high-intensity training on the stroke unit. It was a NIDLR-funded study from 2014 to 2019, and the project leaders were George Hornby and Jenny Moore. There was grant funding for practice-related activities that included a 0.25 FTE physical therapist, a part-time rehab tech, and STEPI monitors, heart rate monitors, and having access to experts in KT and high-intensity training. There was research-related funding for patient chart reviews, consenting patients into the study, and data collection and sorting. Our original implementation strategy was to have 3 phases over 5 years, and that accounted for a sustainability plan at the end. The actual strategy used included 2 phases. The first 2 years were considered usual care. We implemented the gait assessment battery of outcome measures and collected stepping data. There was no encouragement of high-intensity training, and this time frame was done to collect the characteristics of usual care and the outcomes that we achieved with usual care. During the last 3 years, we encouraged the adoption of high-intensity training and continued with the same data collection. So the gait assessment battery that we implemented included the Berg balance scale, the 10-meter walk test, and the 6-minute walk test. A fidelity goal was set at 85%. Clinicians were expected to administer the test at admission, weekly, and discharge. We used multiple different knowledge translation assessments and interventions that we co-developed with the clinicians to implement the test. We started with educating the staff on how to administer the test in a standardized way, how to interpret the scores, and to incorporate the scores into their goal writing. We chose a dedicated day of the week to complete the test and termed it Testing Tuesday. We asked staff to start reporting the team or the outcome numbers during team conferences. We had extra rehab tech assistance available to set out any equipment that the therapist needed and to help them in any way. An audit and feedback was given monthly to each clinician. Each clinician was emailed out everyone's results, and we do believe this method positively affected our quick adherence levels to reach our fidelity goal. This is a graph that shows the adherence levels of staff completion of the outcomes each month for the first 2 years. Along the top, you can see our adherence goal of 85%. For the first few months until month 5, our adherence levels varied. By month 6, staff were consistently at or above the goal of 85%. We initially started giving feedback to the clinicians at month 3 and continued that until month 14. We had 2 formal meetings with the clinicians at month 3 and month 5 to discuss barriers and make modifications, but we did have a lot of informal discussions throughout that time as well. Some factors that we believe influenced our success with this project was that the tests chosen were not time-consuming and they were recognizable. Most of the staff had heard of the test prior to the study. We saw a high level of engagement from clinicians and patients. After we started reporting in team conferences, our OTs would start guessing the numbers that their patients had on the Berg, and they started to administer the action research arm test in a standardized way and reporting that during team conference. Patients and families looked forward to testing Tuesday, and they became really competitive and wanted to beat the week's prior scores. Organizationally, our medical directors and physicians wanted to hear the outcome numbers reported during conference. If a therapist didn't report, some physicians would actually ask them for the numbers. And we do believe the clinician-level method for audit and feedback played a large role in our success with improving adherence levels. It was especially helpful for the clinicians who were not as adherent, since the feedback was given to the entire group. Those clinicians could see that they were lower than the others, and that served as a motivator to increase their compliance. The last time we did an audit was at month 48, and that showed us at a 95% adherence level, and that was after no further effort since month 14. The goal of phase 2 was to adopt the high-intensity gait training intervention. We had a top-down implementation approach at Mary Free Bed. Our administration, physicians, and research staff had initially decided and agreed to participate in the study, and clinicians were notified after. They eventually knew about the study and they were excited about it, but they did not completely understand what high-intensity gait training meant and what that would mean for their practice. They had a weekend education course at the start of phase 2 where they were given the expectations, and throughout phase 2 we encouraged buy-in with multiple different strategies. Here's some of the facilitators that we had. In general, leadership was very agreeable to any requests that we had to support the project, whether that be nursing leadership or therapy leadership. We had funding from the grant to support knowledge translation interventions, and then organizationally, we were able to purchase a new treadmill for the unit and additional heart rate monitors. Environmentally, when we underwent our expansion, we added multiple overhead harness systems and a gait gym that had 2 treadmills with bodyweight support available. And now for the barriers. We encountered multiple barriers over the course of this project. The ones that I will review are the most consistent and the ones that we perceived as the biggest and prioritized. We used an iterative process to identify the barriers, select knowledge translation interventions, and then monitor the adherence. When the adherence was less than we desired, we repeated that process. We trialed many different strategies to overcome barriers throughout the project. Each clinician had their own practice style. Some of them used an NDT approach, but most just did a mixture of multiple different activities. So after the course, staff struggled to shift their focus to majority of gait training. They struggled to allow errors and then to achieve and maintain a high heart rate during the sessions. They also seem to have a lack of understanding regarding the focus on intensity. Organizationally, there were quite a few processes that interrupted the delivery of high-intensity training. Physician rounding occurred during therapy. Some nursing cares occurred during therapy. Physical therapists had been responsible for most of the equipment trialing and ordering before discharge. They were usually responsible for family training and then transfer assessment for nursing staff. And then through the course of the study, we saw a 50% growth in admissions, but we did not change staffing. We also had some medical leaves on the unit that impacted our staffing levels. Now we'll review some strategies that we used against our barriers. To support the de-implementation of current practice, we had access to experts in high-intensity training, and staff was able to discuss clinical presentations and the application of the intervention through case studies and site visits. We had extra rehab tech time available for staff to become more comfortable using the harness systems and getting in patients who needed more assistance on the treadmill. We also used audit and feedback methods for stepping data and for heart rate documentation that I'll show you in a few slides. We ended up educating multiple disciplines to help with the organizational shift in patient care activities that took away from high-intensity training. we were able to reduce the occurrence of physician rounding and nursing cares that occurred during physical therapy, and our OTs were able to assist with medical equipment ordering and trialing. They did more of the family training and more of the transfers with nursing staff. We tried multiple different things to target our staffing issues. We had non-trained clinicians complete online modules. We tried the best we could to keep any patient who came in with a stroke paired with a stroke clinician. If they couldn't and they needed to go off team, we tried to keep the rehab techs paired with them. But ultimately, we probably needed to hire more staff or expand the units who were trained to deliver high-intensity training. This is an example of the stepping data that was emailed weekly to the clinicians. The data was organized by their admission Berg score, or the level of assistance that they required for ambulation, and then it was compared to similar patients during phase 1. The orange line here represents a similar patient that would have, or how many steps a similar patient in phase 1 would have received, and the blue line represents the actual stepping patterns or amounts that they were getting during their inpatient stay. The goal was to keep the blue line higher than the orange line. It's important to note that multiple therapists saw each patient, so this was considered patient-level feedback and not clinician-level feedback. It did not give a single therapist any specific information about how many steps that they were delivering. And this is different than how we gave feedback for the gait assessment battery. This is an example of the heart rate audit and feedback that was given. This shows of the 5 patients who were in the study at the time, the amount of physical therapy notes that included intensity documentation. So it looks like the highest person here is at about 70%. And then it was further sorted to show what percentage of the time with intensity documentation they had reached was in the target zone. So the goal was for 50% of the session to be in that zone. And this was also considered patient-level feedback, not clinician-level feedback. And then Roberta is going to continue with the results of the gait section.
Okay, so the questions guiding our analysis, first question was, were patients similar in usual care and high-intensity gait? These are our patient demographics. In usual care, phase 1, we enrolled 153 patients. In phase 2, implementation, we enrolled 257. Age was similar for both groups in mid-60s. Days post-stroke were similar, about 1 week. And the Berg Imbalance Scale score at admission to rehab was similar for both groups, about 20. We had a couple of variables that were different. The length of stay in the implementation phase was about 2 days longer, and the amount of physical therapy delivered per day in implementation phase was slightly less. But the difference was about 0.3 units per day, which is at most 5 minutes of physical therapy per day. Overall, both groups received about 1 hour of PT per day. So the patients seem to be similar. So the second question is, did we successfully implement high-intensity gait? Well, how was intervention fidelity defined? We had 2 metrics. One was that the changes in steps per day between usual care and high-intensity training. We would expect to see an increase with high-intensity training. Steps per day was chosen based on previous work at RIC showing that patients received most of their stepping during the day during PT sessions. So steps per day was considered a good proxy for stepping within physical therapy. And then the second metric involved intensity, and that would be that more than 50% of treatment time during physical therapy, the patient would be in the heart rate zone. This data was going to be retrieved from patient charts, so it was dependent upon the therapist documenting the heart rate and RPE. So looking at steps per day during implementation, in usual care, we collected data for 14 months, and the average steps per day was 2,494. The standard deviation was large, but that reflects the variability of this patient population. As Jenny and Lauren have described, we used the knowledge to action framework, and we spent a lot of time in this iterative process between monitoring knowledge use, reassessing barriers and facilitators, and selecting new KT interventions throughout the implementation phase. So during implementation, phase 2, we broke it up into 3 sub-phases. and these were marked by 2 points at which we did preliminary data analyses. So the first subphase, 2A, we had 147 participants. It was the first 15 months of implementation. These were all of the initial KT interventions that Lawrence described, 2 visits to Mary Pre-Bed by the principal investigators, weekly audit and feedback of patient-level stepping data that Lauren described. Important to note that this weekly data was not started until month 10 of implementation. And then at one point during this phase, we gave audit and feedback on heart rate documentation to the clinicians. So at the end of the 15 months, we did a preliminary data analysis and saw that there was no change in steps per day between implementation and usual care. Actually, the steps seem to be a little bit less. So this began phase 2B, which encompassed the next 6 months of implementation. These preliminary results were shared with the clinical team. We reassessed barriers, developed new KT interventions, and in phase 2B, we initiated audit and feedback on heart rate and RPE in the zone on a weekly basis, as well as stepping data. Additionally, Mary Pre-Bed clinicians traveled to RHI for further training. So at the end of this 6 months, we did another preliminary data analysis, and while steps per day were now increased to 2,700, it was still not a statistically significant change. So preliminary results were reported again to the clinical team, and at this point, clinicians were given a specific stepping target goal to increase steps per day by 600, and this was determined based on a power analysis that showed that that's the level we would have to increase to show a change overall. So we reassessed barriers, we developed new KT interventions, continued on with the weekly audit and feedback of stepping and heart rate, and actually throughout these phases 2B and 2C, frequently we had almost daily interaction between the research staff and the clinicians and the PT mentor. After phase 2C, steps per day were up to 2,847, but this still wasn't enough to be a significant increase in stepping. And this might have had something to do with the number of participants, just 63 in this phase. So looking overall at steps per day during implementation, usual care, and implementation, there was no change in stepping. The second metric dealt with adherence with heart rate and RPE monitoring. We needed to make sure that clinicians were actually documenting the information first. And we looked at the percentage of TT sessions excuse me, with heart rate and RPE documented. Over all of implementation, just 28% of charts had that information. In phase 2A, just 15% of the charts had that information. Clinicians had been instructed on where to document this information and given wording on how to document this information. And they were given feedback on their adherence just one time. So in phase 2B, when we started that weekly audit and feedback, adherence increased to 45%, and then in phase 2C, adherence was 64%. Importantly, all PT sessions had been audited, which was more than 10,000 sessions. Looking at target intensity in the charts that included heart rate documentation, the target intensity was reached in 33% of PT sessions. So our questions guiding the analysis: were patients similar in usual care and high-intensity gait? Yes. But did we successfully implement high-intensity gait? No. Which left us really wondering what happened. Why were we not successful? And we put a lot of time and effort into this. The clinicians, in talking with clinicians, they kept telling us that they really were increasing stepping with their patients, and they felt that their patients were getting the intervention. So we took a deeper dive into the data to look at stepping in physical therapy sessions. During usual care, the steps per hour during physical therapy were 983. During phase 2A, steps per hour were increased to 1,083, increased again in 2B to 1,276, and increased again in phase 2C to 1542. The difference between usual care and implementation was significant, and in fact, the difference between each phase of implementation was significant. Patients were stepping more during physical therapy. The stepping monitors collecting this data were on the patients during the rehab hours, typically from 8:30 in the morning till 4 in the afternoon. So the total steps per day represents stepping just during that time. So it seems that while patients were increasing their stepping during physical therapy, they were likely decreasing their stepping during the day when they weren't in physical therapy. So in summary, we implemented outcome measures successfully with high levels of fidelity and continued at more than 95% adherence. But with high-intensity gait training implementation, we saw no change in steps per day and inconsistent heart rate documentation. The intervention was not implemented with fidelity, but we saw a significant increase in steps per hour during physical therapy. So our KT interventions did result in significantly improved stepping during PT, although not reflected in total steps per day. So our lessons learned: implementation of this intervention is more challenging than implementation of gait assessments. The feedback type and clinician motivation was important. We've found had better results with clinician-level feedback rather than patient-level feedback. And our best results were noticed after clinicians were given specific targeted numbers, such as adherence levels for outcome measure administration or steps per day, keeping the blue line above the orange line. Heart rate adherence was poor. We know we had poor adherence with documentation. Does this mean we had poor adherence with the intervention? And then we learned it was important to use context to inform fidelity metrics, not just previous experience. In our setting, the number of steps per hour during physical therapy was an important metric to follow.